The UK remains one of the great places to innovate and to do life sciences research and life sciences activity, but the US and China also have quite a lot of money, because a lot of what politicians do is social work. I think experiencing human suffering in that way and human challenges in that way and at such a formative part of your life, you can't help but have a different outlook. How do you relax into leading people? You relax into leading people when you feel secure. If you've got a scientific question, by all means ask science for science's sake, but the question is, at the end of the process, when we've discovered what we've discovered, what are you going to do with it?
Welcome to the Visionary Podcast, where we discuss science, medicine, physical health, and mental well-being. How do you feel about press releases of new drugs? Have you ever come across...
They're very difficult to review from a compliance perspective.
Yeah, I've come across revolutionary breakthrough and stuff, game-changing kind of thing. Is this compliant or a bit naughty?
So I'm not going to be drawn on that.
Okay, all right. That's cool.
But press releases are governed by the same rules that govern all pharmaceutical industry communications. So they should not be promotional in tone. So a press release should not be promotional in tone. That shouldn't. Now, clearly you have to communicate science positively, a positive study which changes the game in a therapy area, a cure for cancer, whatever. And that's a groundbreaking moment. If your data really are practice changing. Where you really struggle with press releases is the quote that you get from a clinician. So quite often the press will want to have a couple of clinical experts, people who use the medicine in the healthcare system, and they may want a quote from them. And
this is allowed?
Yeah, it's allowed. It's encouraged for transparency and openness. It's better to have someone independent. But the challenge is they've often spent their whole life trying to develop new medicines in that therapeutic area, and they've finally succeeded in doing something groundbreaking, and they get very excited. And those are the quotes from the clinicians are often the challenging thing to approve. You very often have to say, look, we're governed by rules, and that's just a little bit too enthusiastic in terms of its language.
Overselling.
Yeah, a little bit. Yeah, so you've got to be careful.
David, you talk about translating innovation into impact, and this is a quote I pinched from you. This phrase suggests that there is a gap between a good idea and helping people. Where do you think brilliant ideas fall off the wagon?
At all sorts of stages along the way, I would say. And I see this. So the new company we set up, PM Life Sciences, one of our sort of missions is to help startups bring innovation to market. And the nature of healthcare, I was having a conversation with an angel investor recently, and he said, the challenge with healthcare innovation, with angel investing in the healthcare space, is that the path is often quite long, requires quite a big evidence base. There are regulatory hurdles. There are compliance challenges. It's difficult to innovate quickly and fail fast. You do need, I think, to innovate in the healthcare space, you need to have a degree of patience to navigate the process, and expertise and money. We have a real challenge in the UK of scaling up. So there was an excellent House of Lords report from Science and Technology Committee published last week, which started with the very provocative phrase, the British economy is bleeding out. And their thesis was that while we have a wonderful environment for life sciences, a great environment for startups, brilliant academic research, actually scaling those startups into large companies is a challenge. Adoption of innovation, gaining finance is often easier in other places, I think, is the hypothesis. The UK remains one of the great places to innovate and to do life sciences research and life sciences activity. But the US and China also have quite a lot of money and are competitive and sometimes get some of these things right. So I would say at all stages along the way. But it's hard. It's one of the reasons we set ourselves up, because I think we work with founders who've never done it before, and it can be discouraging. I think when it takes a long time, you've got to have that patience.
Yeah, it's shocking how brilliant science dies in the gap between research and delivery. Again, science is really the problem. It's the process that it has to go through.
Some of the death of science between research and delivery is about translating the science into a commercial impact, a commercial offering. So that translational element, it was something we thought about a lot at Prostate Cancer UK because we funded a lot of basic science. And the question for me is, always has to be, so what? If you've got a scientific question, by all means ask science for science's sake. But the question is, at the end of the process, when we've discovered what we've discovered, what are you going to do with it?
Yes.
I'm advising a Parkinson's disease clinical trial accelerator, ACT PD, just now. And they've got a really clever idea. They're going to build a platform, clinical trial platform. They've built it, they've opened it, it's opened in a number of centres. They're looking at repurposing medicines to investigate whether these medicines are going to be effective in Parkinson's disease. And the conversation we're having just now, I think it's absolutely the right time to have it, is not how do we get a positive study, but what happens after that positive study. I mean, even in pharmaceutical industry, sometimes because pricing in the US has always been so consistent and so you know, once you've got a marketing authorization from the FDA, the American regulator, you can sell your product and
immediately.
You've got to negotiate with the payers, but there was, I think, much less scrutiny over pricing in the US than there is in the UK, for example.
Maybe that's not a good thing.
Well, you can argue it absolutely either way, and there are definitely challenges in both models. But what it did was it meant people didn't have to think during the development program about cost effectiveness analysis or how they want to bring it to the UK market. So you very often found yourself with challenges in getting reimbursement in the UK, having to collect additional data. I've always said, set out with a scientific idea, but have a clear plan of how you're going to get it to a patient. What is this going to do that improves patient care? And how do we need to build that evidence base?
I'm now curious about those drugs that do not make it to the NHS. They are there. They have been made already. Would they be available in the market for the private sector?
Sometimes.
Doesn't that mean that people with limited means might lose out on buying, because they usually go to the NHS, they don't go private. Those who go private are those who have lots of money. So yeah, an economic issue again. We
have less of a problem with that in the UK than we do in the US, for example. So, but yeah, it is one of the great challenges. We see it in lots of other areas, though. I would challenge you to go and find yourself an NHS dentist.
Oh yeah, I do have one.
Well,
I do have one.
Incredibly envious.
But just because I used to teach the dentist, used to teach his children Arabic.
Okay, wow.
Okay, that's the only reason. Said to me, "Oh, we will open another clinic in Sevenoaks. That's why my dentist is in Sevenoaks." So I said, "Okay, let's join," and I don't have to pay for it like I'm an NHS, so which is super rare in Kent.
It's rare. It's a real challenge now, and I think it's one of the real challenges that we have in this country. I think it's a sort of existential political discussion. What are we? Private education continually raises its head in the political discussion. Private dentistry, private healthcare.
I wouldn't be able to afford.
Sometimes you will find medicines available in private setting that aren't available to the healthcare system.
Hi, I'm Hala, your host today. If you're enjoying what you see, please hit that lovely subscribe button. It will mean a lot to us. Or maybe a small podcast now, but with your support, we can build this channel together, one step at a time. Thank you so much for being part of it. Going back to the start of your medical journey, you started as a surgeon. How does that real-life hospital experience shape the decisions, the difficult decisions that you make today in pharma, in policy? I'm asking because I think, and I'm I don't know what I'm talking about most of the time, but I think there might be an inherent flaw because those who make medical policy, they have never held a patient's hand before. So they probably don't know what people are going through, but they are at the top making medical decisions. but you straddle so many sectors.
Yeah, I mean, so okay, that's an interesting way of phrasing it. I think those experiences were very formative in everything I do, and in everything I think. I think there are some things that you get to do in life. It's really interesting. Most people, most people's experience of the world is really narrow. That's the reality. If you work for if you're an accountant in a business and whatever, your friendship group will typically be quite homogenous. Your work colleagues will typically be fairly homogenous. The reality is my professional experience is homogenous, right? I mean, that's my professional experience. The very interesting thing about interacting with the public in any shape, whether you're an ambulance driver or a policeman or a nurse or a doctor, dare I say it, even a politician, actually, because a lot of what politicians do is social work. Really, if you think about the
Yes.
casework they do in their communities,
I can imagine that.
they do a huge amount of interacting with all sorts of people, many of whom are in deep crisis. To go to your MP for help requires you to be in a difficult place quite often. So I think our politicians do get this, actually, interestingly. I mean, they live in a bit of a Westminster bubble, but I think they do also live in constituencies with diverse populations of people, and they interact with them in a professional capacity. You get to see people when you're a doctor. You get to see people from every walk of life, often at the most vulnerable point in their life. And for me, it'd be interesting. I left clinical medicine on just after my 30th birthday, so I've never been a doctor in my 30s.
No.
I've been a doctor in my 20s, my teen medical student, and a doctor in my teens and 20s. I often look back and think about the things I did and saw and had to deal with psychologically as a child. I mean, I think I'm probably not a child now. I'm nearly 50. I'm 48 years old. I'm probably now don't feel like a child. But I look back to David in his 20s, handling life, and I was a surgeon, right? Handling life and death, handling complex diagnoses, breaking bad news, challenging situations. And I think it does shape all of your worldview subsequently. I think experiencing human suffering in that way and human challenges in that way and at such a formative part of your life, you can't help but have a different outlook.
Yeah, and I can imagine that emotional or emotion-driven decisions can be financially unsafe in a population level system like the NHS. So maybe those who make decisions about new drugs, for example, as we've been discussing, should take a bit of an unemotional stance so they can make the right decisions. That's sometimes how I view it. And I think this mirrors a number of institutions in this country and other countries. Like, for example, I've been pondering about this in my child's school, and I think this applies to a number of schools I've been in touch with as well. All the teachers are brilliant, are kind, are sensitive, are emotional, are like brilliant. The head teacher? And I mean, when you think of it, how would she or he run a school efficiently, properly, with rules and regulation if she's touchy-feely, lovey-dovey? Even if she were before, she had to take a different character to be able to run a school. It comes with the system, kind of thing. Yeah, this is off point a little bit, but
I think your approach to leadership is shaped by leadership's a really interesting question. Your response to your approach to leadership is shaped by your formative experiences as well.
I was raised in a nun school.
You were raised
in a nun school.
Okay.
That's why. If we dig deep into this
again, we're stringing to Alain Breton's podcast again. It's becoming philosophy rather than science. I concede that, but I think you've got to decide what kind of leader you are. And I watched I watched lots of different, and I don't think I knew I was doing it, but I watched lots of different leadership styles when I was going through my formative years, my training years. I worked for a couple of surgeons, both of whom though were amazing in their way. One was a flamboyant operator, wonderfully good at what he did, quick but really safe, just brilliant. The other, much more meticulous, much slower, much more thoughtful, very similar outcomes. You know, I mean, if anything, the more sort of flamboyant, older surgeon was probably the better surgeon, actually, if I had to choose. And they had a completely different leadership style as well. And I think it was based on the same issue. So the more flamboyant surgeon was much more relaxed, much more easygoing. He demanded high standards, but he did it in a really kind, supportive, considerate way. The much more meticulous surgeon was much harder on people, gave some people a really hard time at times. And I reflect on that. Leadership it's a function of who you are, how comfortable you feel. You know, how do you relax into leading people? You relax into leading people when you feel secure. And I think if you don't feel secure, there's a risk you cannot relax into leadership. But yeah, it's a really interesting question. How did being a surgeon in my 20s shape me? I think it's created a sort of humility. I hope.
I could see that clearly.
Oh, can you? Good. Okay.
Yeah.
I'm glad.
And the priority in all the discussions now for you is always patients and patients' care and how they could benefit from whatever you're doing.
Yeah, I think that has been a real big... In society, I really care about... People will argue with me about this, but I really care about our country. I actually do genuinely care about Britain. It's funny, we talk about identity. I mean, my wife's a Polish Australian. I'm an Irish migrant to the west of Scotland, and we now live in England. My kids don't know what on earth they are in that context.
Doesn't matter, really. Does it matter? Do we have to pinpoint a certain identity? People often ask me, especially the new people that I meet, how do I define myself, where I am most comfortable? But I really, maybe I can't define it. I'm most comfortable, I'm happiest, I'm most supported in England, in the UK. I'm most respected. I feel safe and happy here. So this is home. This is where I belong. Those are the people who support me. I support back. Not back in Egypt.
I think that's lovely to hear, and I think that's right. I think your identity is a little bit about where you feel safe and comfortable. And I've been lucky. The UK has been great. I mean, I'm Scottish. I was born here, but we've been very lucky to raise our children in a great country. And I think so. I do. It's not always been driven by patients individually. I mean, I've stood for Parliament and I do a bit of mentoring for the Social Mobility Foundation. There's lots of things that I do, and it's not always about patients, but it is always about people. It is always about trying to make things a bit better for the people you interact with. They don't remember what you did. They remember how you made them feel, right? That's the old slightly trite adage, but that's kind of always driven me. And I was very acutely aware in every interaction I had in medicine that it didn't matter to me. It was another interaction. I'd probably see 50 patients that day, whatever I was doing, and none of them would some of them do stick out, interestingly, but most of them would not stick out. So how many? I was a surgeon for 8 years. I was sort of seeing 40 or 50 patients on average every day. I mean, you can do the numbers, right?
Wow.
I can probably remember the names of 6 or 7 people that I and maybe another 10 or 12 people whose names I don't remember, but I do remember the interaction out of thousands of interactions. My suspicion is almost every single one of those people who had a significant interaction will remember me or remember it because it was so substantial to what happened to them. That's the thing you've got to kind of remember when you're in these situations is the power dynamic's really interesting. It's very different. It's very routine. being in a hospital when you're a doctor. It's not very routine being in a hospital as a patient.
PM Life Sciences. You co-founded PM Life Sciences with Dr. Please correct my pronunciation, Sheuli Porkess.
Beautiful.
Oh, thank you so much. Okay, what is the problem that you guys are trying to solve?
I think we've talked a little bit about it. I think what we would like PM Life Sciences to be is a vehicle for helping to get innovation. I mean, we're 5 or 6 weeks old, and I think we are still trying to work out where the impact is. But we're working with a number of startups just now to help those startups take their product through the complexity of the development program. We would love to build an offering for the biotech sector. I think one of our challenges, one of the things, having sat on the Cancer Drugs Fund, having sat on the Scottish Medicines Consortium, having done lots of launches, I've often said I wish I'd been involved earlier on in these development programs. I would have shaped differently the way we collected evidence and data and brought those medicines to market. I think we could have done it quicker. So I'd love to build a bit of an offering for the biotech sector. We're working with a little company called Health Exbridge that a colleague friend now set up recently. So we're still trying to formalize what that relationship looks like. But that's a really interesting change management business. So the founders are very senior NHS executives and a very experienced organizational change management, leadership training professional. And they're building an organization who's really going to help industry and the healthcare system work to streamline how they do things and how they introduce innovation. Yeah. So there's some really interesting avenues that we could take PM Life Sciences. And I think, as I say, we're trying to nail exactly what it is we do. But ultimately, it will be helping people with clever ideas get them to patients.
Yeah, amazing. We're not a business podcast, but if it's medicine related, we're in. When you meet a brilliant team with a very clever idea, what tells you that this idea can scale responsibly versus clever idea, bad strategy?
Yeah, it's a great question. And you can sometimes fix a strategy. That's not a major challenge. I did a little bit of angel investing before, while I was still working in the pharmaceutical industry, employed by companies. I am still in the pharmaceutical industry, but still employed by companies. One of the really important things is the founder and the team. For me, if I'm going to support something, the founder really matters. The quality of the people around them, the credibility, how well they understand what's going on, what their perseverance and determination looks like. I think that's really, really important. The idea, there's got to be a clear problem, a clear solution, protectable IP. So you do see people coming with stuff that you just think, well, particularly in the AI era, if you can't patent something in a way that doesn't allow someone else to bring in something very similar, the reality is you're just going to have a crowded marketplace. Lots of people come to me with apps.
Yes, it's the next best thing.
I don't get very excited by many of it. Every now and then someone comes with something really clever, but not often.
Yes.
So yeah, I think it's a brilliant founder team, an addressable problem, some clear IP, some protectable IP, and you can fix most plans. Those are the basic sort of building blocks, I think, of a potentially winning strategy.